that would be great. All right, thank you. Now, as I continue, okay, sorry. So what is GLAD? What does the acronym stand for? It's Good Living with Osteoarthritis from Denmark. And the actual program, so today I'm actually giving you an overview of the GLAD program, but if you subscribe to the actual community program, which is delivered in a lot of great locations, which I'll walk you through, it basically involves 2 90-minute education sessions. There's an individual assessment, which includes a couple of functional tests and online questionnaires. Then there's 12 supervised exercise classes over 6 weeks. And then at the end of that period, there's a retest of those original assessments. And then there's another follow-up questionnaire. And then the last questionnaire is followed up 12 months later. Now, it's really important that you complete the questionnaires because the program learns on your findings and can continue to be improved to help with government funding from the government and private health insurers so we can identify osteoarthritis as a key chronic disease that should be looked at in our healthcare system in Australia. Now, education is a vital part of the GLAD program. Understanding osteoarthritis, including your potential treatment options and their likelihood of helping you, is the first step for you in improving and managing your hip and knee arthritis. Okay, so your hip and knee pain. Those are the main objectives. Now, if we're looking at how common osteoarthritis is, it is the most common lifestyle disease in people over 65 years of age. It's more common, believe it or not, than hypertension, high blood pressure, and type 2 diabetes. Think about that for a minute. So it's one of the most common reasons why people see their doctor in Australia. Persistent hip and knee pain. If you're here, it's probably because you are suffering from the significant pain problem. So a very early sign of osteoarthritis is persistent hip and knee pain, and even in younger people. So you can see there 30% of people aged 50 or above report ongoing hip and knee signs. Now, what's important for us to determine is the definition of osteoarthritis. It is a lifelong joint disease. And it can start without any obvious reason, which is really important. It can come on pretty innocently and then quickly ramp up and become a big problem. Essentially, the cartilage on both ends of your bones changes in structure and can thin over time. So the structures involved could be your joint capsule, ligaments, your muscles. The underlying bone is also affected. The leading cause, the number one cause of osteoarthritis in people aged 65 years or older is physical inactivity. And osteoarthritis is often described as a wear and tear disease, but this is a description that should be avoided because it leads many people to think that they cannot and should not be physically active. And as I'll present to you, this is fundamentally wrong because the cartilage acts like a sponge and it needs moderate load through physical activity to regenerate itself. Okay, and I'll walk you through this. So the focus of the structure of the cartilage is also, focusing on the structure of the cartilage itself can be unhelpful because the causes of pain and disability associated with osteoarthritis is quite complex, which we'll discuss next. So routine scans like X-rays and MRIs are no longer recommended for people with osteoarthritis, because it's important to spend time understanding the multiple factors specific to your individual situation, which might influence your pain and your unique disability. So it's a very much a case-by-case scenario, and that's really important to know. So what I'd like us to consider is the factors contributing to pain and disability in people are quite complex. And even though the structural changes play a role, there's many factors, some less obvious, which each person can contribute to the osteoarthritis. So, for example, comorbidities like obesity and fatigue play a role. The following other symptoms can make your pain and symptoms worse, like muscle weakness. You can see here the guy on the left well, it's the same guy, but the left thigh you can see is atrophied, a lot weaker compared to this bulky, thick muscle here. You can look at physical load. So if you actually sustained an injury, that can be a key reason for osteoarthritis. There could be less obvious reasons like social stress and isolation, fear avoidance behaviors, your confidence, depression, your fear of damage and lacking confidence in the joint, and a lot of catastrophizing and coping and other negative beliefs. Okay, so just be mindful of many of these factors can be changed with appropriate guidance and support. Just give me one moment. Yes, thanks for the heads up there, Jess. I'm just going to ask again, people, if you can mute yourselves, that would be helpful. Let me just try my best to mute. Cool. All right. Sorry about the, sorry about that. All right, moving along. So one of the things to ascertain with the management of osteoarthritis is correctly diagnosing it. Now, did I skip a slide here? Yes, I did. So, sorry. Here are some things that can't be changed. So we call it non-modifiable risk. Now, you can't change your age, you can't change your sex, and there's hereditary signals, let's say, that come from mum and dad that you can't modify. So osteoarthritis in terms of age can be more frequent with increasing age because it's irreversible. And given that osteoarthritis is irreversible, the symptoms can be reproduced and can often disappear, which is what we can assist with you today. Pain is also dependent on muscle strength, more so than on X-ray changes. That's why there's less of an emphasis on imaging. I think it's a great tool to help arrive to better decision-making, but the imaging is not a diagnostic tool. We don't make decisions solely based on your scan. So very important to note. In terms of sex, osteoarthritis is more common in women, and women often have arthritis present in the hands and knees, and the men more so in the hips is more common. During the middle age, more men than women have knee osteoarthritis. So that's important to note. It may be a situation where men may have had issues in their working life in sport, which presents with osteoarthritis as they get a little bit older. In terms of your genetics, your hereditary nature, if one or both parents have osteoarthritis, the risk of your child having osteoarthritis as an adult is increased. And some of this can be modified by adopting a healthy lifestyle. Now, how's osteoarthritis diagnosed? This is really important, guys. X-ray will show a reduced joint space. So you can pretty much see on the left versus the right, there's a big difference in the space of the joint. There could be osteophytes, which are little jagged bits. So some of the bones can start to lay new bones down and they're not smooth as they should be. There could be cyst formations. There could be increased density of the bone beneath the cartilage. And it just gives the practitioner an idea of what you may be suffering with or the health of your knee. The other way to diagnose osteoarthritis is based on your symptoms. So your existing risk factors, your examination on what your doctor or your physiotherapist can determine, and also your subjective signs, what you're reporting in terms of your pain and symptoms. Now, it's always the patient's symptoms and not the X-ray changes that guides the choice of treatment. Because scans can be an important case of, say, a traumatic injury, if you fell over in a sporting event, or if you got hit by a car, or if there was basically a traumatic mechanism. Osteoarthritis can be a potential development, and in this case, with an acute injury, sure, imaging is indicated. But in almost all cases, the diagnosis of osteoarthritis can be made based on your pain and symptoms that you report, a clinical examination, and the risk factors specific to you. So your age, your sex, and your genetics, essentially. So X-rays are still needed to help in making the final decision of whether we need to escalate your management. So, for example, undergoing a joint replacement. But since those are only with small or moderate structural changes, you may be less likely to respond to surgery, which we'll walk through. Just some quick slides on anatomy. So the structure of your knee, a key structure here is your cartilage, which lines the end of your bones. They're surrounded by this capsule, and within the capsule, it houses synovial fluid, so it bathes inside the knee, which is how the cartilage nourishes, which nourishes the cartilage. The ligaments and the external muscles help stabilize the knee. Now, it's important to note that the cartilage has no blood supply, so it gets its nutrients from the nice synovial fluid within the joint capsule. And so the dynamic load, so through specific exercise, the cycles of loading and unloading the joint is helpful in nourishing the health of the knee, because your cartilage acts like a sponge. So as the pressure is built through weight bearing and exercise, it pushes the fluid out, say, of the cartilage. And when you are resting or you're non-weight bearing, the pressure is then sucked back into the cartilage, and that's how the mechanism of nutrition and health assists with cartilage health. So regular exercise ensures cartilage health, which is improving the efficiency of drawing the synovial fluid in and out of the cartilage. So if you want healthy young knees, specific weight-bearing load is important, especially for the cartilage. Now, the basic anatomy here, just as an overview, there's lots and bits and pieces that come in and act around your knee joint, and we'll walk through the hip shortly. But a lot of the benefits comes from a measured exercise program. And if you can see all these different structures within the knee, they all too have nerve endings, so they can send pain signals to your brain, which suggests to you that you're suffering a knee injury. So the reason why we're moving away from a wear and tear disease of your cartilage in the knee is because the fact is that there may be other factors causing the pain coming from your knee, not just the cartilage. So it's important to pick up the signs and the symptoms of how you're developing your specific knee injury. Okay, so if we shift gears to the hip joint, very similar in terms of having similar structures to the knee. The main difference is the meniscus. So there is a cushion within the knee called a meniscus. In this case, the hip doesn't quite have a meniscus. There's something called a labrum, which is similar in structure and function, but those are, they're treated with the same sort of protocol in terms of our GLAD program. Now, I would say this is the most important slide. What happens with osteoarthritis? Now, the structural changes in your joint may be due to a lot of different reasons. It may be that the cartilage is exposed to too much load all at once. So let's say you've been relatively inactive for a period of time, and then all of a sudden you want to join a gym program, and then you go from 0 to 100. That can be too much of a load, and if you fall and land heavily on your knee, that could bear an acute injury. So that blunt force can cause an injury to the knee. What happens though is if you subscribe to a gym program and you may be just not strong enough, there's too much load over a long period of time and you develop an overuse injury. Now, the other side of that same conversation, or the two sides of the same coin, is too little load. Because if you have tissues that need stimulus to remain strong or to regenerate, if you're not putting enough load into that joint, it can start to weaken, atrophy, and waste away. So in our previous slide where we're talking about the health of your cartilage, it needs a specific load which is customized to you and your conditioning in order for the cartilage to be healthy. Because the cartilage being one of many structures in the knee, if there's just purely not enough physical activity, unfortunately, you may be starting this snowball effect where you start to accelerate the osteoarthritis presenting in your knee. So remember, with either your hip or knee, it can be made worse by many factors that you may not be immediately be thinking about, such as poor sleep, nutrition, stress, and psychological factors. which again we'll touch on as we go. So it's not purely a physical presentation that we consider. There's also other non-physical mechanisms that we should consider as well. Now, the signs of osteoarthritis, it usually starts in one joint. Symptoms slowly develop and then may stop completely. So it's almost like a roller coaster, and that's the frustration with managing osteoarthritis. It's not consistent. It can change day to day. Completely understand. And the experiences can vary from person to person. Stiffness, especially in the morning and after maybe sitting down after a long period of time. So say you get out of bed in the morning, first couple of steps are shocking. Then as you warm up, it eases. Then you sit down, have a nice meal at lunchtime. And then you get up after your half an hour meal and it stiffens up again. You know, these really short-lived stiffness episodes. Does that describe what you're seeing currently? You know, in the beginning, the pain occurs only during weight bearing, and then later you may present with aching in the knee at nighttime. It's because the inflammation in the knee, the response to the injury, gives you an inflammatory response. And, you know, a short-term measure that may be offered is a steroid injection into the knee, which may give you momentary relief for maybe, say, weeks rather than months. But if we're not addressing the underlying deconditioning and inactivity, then unfortunately, the steroid injection will fade away and then the problem will represent. So pain associated with osteoarthritis is not just from the, not from the articular cartilage. It actually comes from the bones, the ligaments, and the structures surrounding the knee. So this is the reason why symptoms can vary and be often quite random, because you have different mechanical structures, say ligaments, the joint capsule, the tendons. They can give you pain signals. And on top of that, you also got the inflammatory response, the aching at nighttime. So you can see here that, say, in the hip, you get referral patterns in this ball that jams into the socket. You can almost have referred pain deep into the groin, so very high up and to the front of your groin. It can sometimes present to the inner thigh or down to the knee. So these are common referral patterns from your hip. In the knee, you can have very specific sites. So you can point to it and pin a flag. The pain is right here. Other times you can hear audible crunching and grinding sounds, which aren't pleasant. What can accelerate your degeneration in the knee is the bow-leggedness or the knock-kneedness, and if there's any previous mechanical signs like the knee giving way. Now, common problems that you may observe in your challenges in managing osteoarthritis are functional everyday tasks. You know, do you struggle putting your socks and shoes on in the morning? Standing up from the chair, or even the loo? The toilet is a long way down, and you know, we may use it a couple of times a day. So there's a couple of squats and it's a struggle. Walking for long distances, going up and down stairs, running, household activities, gardening, leisure activities. What of these activities do you currently have trouble with? And maybe what other activities not listed do you find challenging due to your osteoarthritis? Working with your physiotherapist, you can develop realistic goals specific for your needs and for your goals to improve your ability so you can do the things that you want. And this GLAD program can help achieve many of your goals, but there may be other exercises and treatments that can be added to help you get there. Now, one factor to consider is, in these next few slides, some things that you may not directly denote to osteoarthritis, but it's important for us to have in the conversation. So one of these is fatigue / tiredness or lack of energy, because people may stop doing physical activities that they like due to feeling tired or lacking energy. Once they've done all the things that you've needed to do, the must-dos, your to-do list for the day, you're exhausted. The thing is, though, fatigue cannot be slept away. Fatigue is different from ordinary tiredness. You know, with ordinary tiredness, it's what you feel when you haven't gotten enough sleep. So if you've managed to get some great sleep, you're recalibrated and that tiredness should dissipate. Fatigue, though, is a common response when there's an inflammatory disease, when there's a chronic inflammatory joint disease, or if you have other comorbidities, lifelong illnesses, that can also cause fatigue, which is going to present with two factors that you may observe: the long-standing pain and stiffness, and this fatigue. So we know that poor physical and psychological status may increase fatigue, but it's important that we address this, because what can you do to decrease fatigue? It kind of seems like a bit of a misnomer here, but being physically active and being in better physical shape helps combat and reduce fatigue. So start slowly and gradually build your activity levels, and having the guidance and supervision of a professional helps. So if you feel that fatigue has been one barrier for you in trying to manage your osteoarthritic knee or hip pain, this is the reason why. There may be other chronic inflammatory conditions you're concurrently managing. Before I said the other slide was most important, I would say this is the second most important slide, guys. So pay attention here. Now, this is the treatment pyramid for osteoarthritis. Now, treatment aims to reduce symptoms and improve function. Okay, reduce symptoms, improve function. Now, every person seeking care for joint pain should be offered education, exercise, and weight reduction if this is needed. Just give me 1 second. There we go. All right. Cheers. Sorry. So every person seeking care for joint pain should be offered education, exercise, and weight control. So if you can see this pyramid, this should be the first line of treatment. Whoa, what's going on here? There we go. Now, we'll touch on these second line and third line treatment, but this is basically the foundation. If the first line of treatment doesn't lead to satisfactory outcomes, then it could be complemented with pain medications, other modalities like TENS machines, so electrical stimulation, manual therapy from your physio, braces, insole support from a podiatrist, and other aids, and maybe in some instances, an injection, cortisone injection, for example. However, these strategies cannot address the range of factors contributing to pain and disability. So, for example, the way to improve strength is to complete an exercise program. There's just no way around that. So for those of you or those in the population here that are struggling with osteoarthritis, if you've explored your first line of treatment, you've complemented that with a second line of treatment, then for very severe symptoms, and in these studies within GLAD, 10 to 15% of the population, surgery may be considered. And those options may be a joint replacement, where the joint surfaces are replaced with a prosthesis, a metal or ceramic, an osteotomy, which is a removal, or they remove parts of the diseased bone, or an arthroscope. Now, the first line of treatment, if you observe that in this pyramid here, if we just explore that a little bit further, what does that entail? Well, it's essential to understand the possible causes of osteoarthritis, what could be done, and the importance of self-management, since it is a lifelong disease. Exercise is effective for pain relief because different types of exercise like walking or strength training are effective in relieving pain. Neuromuscular exercise is just as effective for pain relief, and in addition targets the osteoarthritic joint and improves stability and trust in the affected joint. So you get more confidence as you use it over time. And the dose of the exercise is really important. More is better. And the reason why we say that is because inactivity has been shown to accelerate the degeneration of your knee. So starting somewhere and persisting with great supervision is a great thing to consider. During neuromuscular exercise, you'll practice doing things every day, like getting up and down off the floor, rising from a chair, walking with good movement quality, and loading the joint in the best possible way, unique to your situation and your movement pattern. So this is really what makes the program unique, because the activities are applicable to your everyday life. So with one important note that I'd like to add here is, in terms of the weight management, normal walking, if we consider just your normal day of walking, The knee joint is loaded with at least 2 to 3 times your body weight with each step. Being overweight increases the risk of cartilage and the joint becoming overloaded. And so a relatively small reduction in your weight, well, has a big effect on the joint load. So for every kilo that you lose, the load that's reduced on the knee and hip can be at least 2 to 3 times that factor. So an improved diet and exercise plan to reduce your weight is likely to be beneficial in reducing your pain and improving your general health. Now, all people should be offered exercise, and this is a clinical guideline from the Royal Australian College of General Practitioners, and they recommend that all Australians seeking care for osteoarthritis should be offered exercise. That's pretty much complements what the GLAD pyramid suggests, where the first line of treatment is education, exercise, and weight control. So GLAD offers a great option and can provide you a great protocol to move forward. The second line of treatment varies in levels of evidence and their supportive use, but they're often associated with short-term pain relief. The second line of treatment should not replace the first line of treatment, guys. So there's no way around avoiding getting to know what it is about your health and osteoarthritis, getting some load across the joint, and getting your weight under control if that's a concern for you. Now, additional treatments provided by a physio can involve shoe inserts and orthotics, taping and bracing, some great techniques like dry needling or acupuncture from a Chinese therapist, manual therapy, gait aids. There's some great bits and pieces there, but again, we're reinforcing this idea that it should not replace the first line treatment of education, exercise, and weight management. So think of these knickknacks as complementary, only complementary, but they won't be effective in long-term management of your lifelong joint disease. In terms of pain medications, obviously seek your doctor's advice and approval, but in short, paracetamol has been shown to have a few side effects, but can help with pain in short term. But there are no long-term benefits in regular use in comparison to a placebo. So long-term paracetamol use versus a sham treatment, no real change. In terms of a non-steroidal anti-inflammatory, they're estimated to be 3 times more effective for pain relief in the osteoarthritis population compared to paracetamol. However, you've got to be careful because there's a greater risk of stomach ulcers and some nasty stuff there with people struggling with chronic diseases like heart disease or asthma. So always consult your doctor about what pain medications might be appropriate for you as you're co-managing osteoarthritis. So again, we recommend that these treatments are not used in place of first-line treatments, such as education, exercise, and weight management. Again, think of these guys as being complementary for your care. Opioids, strong painkillers having morphine-like effects. Fortunately, there's no evidence that strong painkillers, opioids like Oxycontin, Endone, will help. In fact, they may even make pain worse in the long term because as such, research quoted within the GLAD program in that 1 in 550 people who regularly take opioids will die from an overdose. So a big yellow, red flag, flashing neon light sign there. Be very careful with these strong medications. And the guidelines within GLAD and around the world is actually recommending that we avoid taking strong opioids. So if you are taking opioids, please speak with your doctor about strategies to reduce your dependency if this applies to you. Now, cortisone is a steroid and it can be helpful very much in the short term with pain relief. But in the long term, it hasn't been shown to provide long-term relief compared to a placebo. So comparing, say, a cortisone injection to a saline joint injection, no difference, unfortunately. So if you got some great relief from it, great, but it's not usually something that's recommended for long-term management. Apart from minor risks with an invasive procedure like an injection, you've got to be careful of joint infections and be mindful that repeated cortisone injections over, say, a 2-year period leads to a more rapid cartilage loss. So definitely want to avoid that. Other types of injections, just so that you're aware, Synvisc is a common procedure of hyaluronic acid, and it's an artificial fluid, which I touched on before, which replaces that synovial fluid that nourishes the knee. Now, unfortunately, there's limited evidence in the short-term benefit and risks of a Synvisc injection, and may actually worsen your condition. Other modalities like PRP injections, so platelet-rich plasma, can introduce growth factors into your joint because it uses your own blood and it's processed and re-injected into your own joint. It's kind of less aggressive than other measures, but again, there's limited evidence that it helps with pain for up to 12 months, but unfortunately the research isn't conclusive. So again, I keep coming back to the idea of first-line treatments in that pyramid I addressed earlier of education, exercise, and weight management is the best strategy to employ. So think of Synvisc injections, PRP injections, cortisone injections as complementary on top of your primary base of the first-line treatment. Now, in terms of surgery, at the very top here, this should be reserved only for people that are not responding to the first line of treatment and the second line of treatment. Now, working as a physiotherapist within the clinic here and across locations in Melbourne, it's so unfortunate for me to see people who skipped these two first stages and went straight to surgery, because the underlying weakness, global weakness, let's just call it, starts to put the same pressures onto the knee, and then unfortunately they start to develop knee pains again. So if you're here or if you're watching the recording and you're in that subset of the population, I empathize, because this is really the protocol we should be following. If you are presenting to a professional and then you're given the appropriate advice and it dissipates and removes your pain and you're highly functional and you're back to the old Bob and Jane as you were, how good is it to avoid surgery? You know, I think no one wants to use the S word lightly, so with surgery. So I think this is a good program for you to follow and to employ the strategies here. So surgery is a last resort. Now, in terms of, I'll just run through these slides a bit quickly. So just so that you're aware, options available to you is an arthroscope. So it's a keyhole procedure. They generally hop in there, and with minimal like external damage, they can clean up the knee joint, or it's called a debridement. While they're in there, they can trim some of the jagged bits away. So cutting out parts of the diseased meniscus, for example, they can trim back some of the diseased cartilage. But again, we're trying to avoid surgery, and the best guidelines are to ensure that you are strengthening with an exercise program, you're managing weight loss if it applies to you, and that you understand what osteoarthritis is. So in terms of arthroscopes, it's generally employed to reduce pain, and the procedure is usually helpful in about a 30% figure of the population. So it's been shown that arthroscopies, unfortunately, are no more effective than a placebo, so a fake surgery, believe it or not, in multiple studies with people with knee pain. So I guess it's ultimately your decision, but if the science suggests that people who are offered a surgery and actually go through with it versus people who don't have surgery, part of this could be due to the post-surgical rehabilitation, maybe better managements of load, the reduced fear of exercise, or maybe a number of other factors. So, the age range of these studies were across 35-year-olds and older. So it's not just the older population. At the moment, in the knee, guidelines all around the world recommend that arthroscopies should not be performed for people with knee osteoarthritis. Okay, should not be performed at this stage. So basically, the science doesn't support it. In terms of the hip, though, there's less guidance around whether arthroscopies are appropriate, but more will come in these coming years. In terms of joint replacement, this is a good operation procedure for the right person, and it should not be provided to people who have not adequately trialed the first-line treatments of education, exercise, and weight management. Most people with knee osteoarthritis, though, will delay surgery following the completion of a program like GLAD. And the remaining, let's say 2/3 of the population will delay for at least 2 years. So you're buying yourself more time. And although most people may benefit from this big procedure, not all do. As with all surgeries, there's risks and potential complications. So completing an exercise program first in the comfort of your own home means that you may be prepared better for surgery and better outcomes post-operatively. If you have osteoarthritis in only one part of the knee, so not the whole complete knee, the surgeon may offer you an osteotomy. And this procedure takes a wedged part of a bone of the lower leg. So they basically grab a bit of bone elsewhere and then they pop it into your knee to redistribute the load. And obviously this is a call coming from the specialist, from the orthopedic surgeon. Okay, so essentially why we're here, we're looking at offering treatment options to you or someone that you know in looking to reduce your symptoms and improving your function. Every person seeking care for joint pain should be offered education, exercise, and weight reduction if needed, because this recommendation is supported by Australia's national guidelines for osteoarthritis care. Now, if the first-line treatment doesn't lead to satisfactory outcome, it can be complemented with pain medications and other options that are offered to you that I've touched on earlier, in some instances, injections. However, these strategies cannot address the range of factors contributing to pain and disability. So again, the only way to improve your strength is to complete an exercise program. And for those, unfortunately, who do not respond to the first and second line of treatment, and the numbers around about 10 to 15% of the population, then surgery may be considered. Now, one of the main many benefits associated with completing the GLAD program is setting goals and making consistent progress. Now, there's a lot of range of other treatment options available, but if you're not reaching your goals or that maybe there's other options available to you, these are the things that we're looking to provide for you. So do you find often you are avoiding certain tasks around the home, or as you are bending to reach and lift something from the ground, you're putting more weight on your right knee because your left knee is unhappy? Over time, you'll only negatively reinforce disuse of that knee. And unfortunately, it doesn't get stronger and more pliable over time. It actually weakens, deloads, and becomes more pathological. Now, as you get more active with more guidance, the pain improves. You're then obviously looking to improve and enjoy your life, living your best days. Ultimately, we want to take less and less medications, less time off work, and reducing the likelihood of surgery. Now, there's some great resources. I'd point you to the actual GLAD program online. They've got some great contacts and locations that you can take up the group training program. Now, this is a first of a series of information sessions that I'll run. The next couple will be a lot more practical. I think it's really important that we just touch on the main mechanisms of how osteoarthritis presents and other factors pertaining to osteoarthritis that you may not have considered. So please review these resources. The Royal Australian College of General Practitioners, they have some great resources online too. Now, right now, if you're needing additional help, the GLAD program is usually a small group program, but right now within Westgate Health, we can offer you one-to-one sessions for your specific care. You can qualify, given it is a chronic condition, you may qualify for a care plan where there's no gap fee within our Westgate Health location here. So feel free to raise this with your doctor, and your doctor is supportive in referring you to physiotherapy. I'd be more than happy to help you. If you have any questions, I'll be happy to answer any concerns that you had or any specific questions that you have. In our next session that we'll announce, I'll actually go through more practical things, maybe some do's and don'ts, some challenges. But today I just wanted to start with a bit of an overview of something that you may have heard about, the GLAD program, an initiative all around the world, but driven by La Trobe University. And yes, I just wanted to thank you for your time and potentially sharing your experiences with me. Thank you very much. All right, guys. Thank you for listening to my monotonous voice. I am looking to see if you have any questions at all. I'm happy to have a chat, but be mindful that there's upcoming sessions, so don't feel like you'll miss out. And if you have any questions, if you're watching this recording back, we'll find a way to get those questions to me, and I'm happy to address questions in a follow-up session. So feel free to, I'm just seeing, oh, thank you, Tony. Thank you, Tony, for your feedback. I think people can get I get a bit self-conscious because, I think my voice sounds a bit strange, and you kind of get self-conscious. So I appreciate that. Thank you. I'll just pause. So if anyone has any questions, feel free to pop into the chat or unmute and throw me a curveball. I'm ready and willing. Thanks, Joan. Appreciate that.
I'm about to have knee surgery in the next couple of weeks for a reconstruction. I'm sort of a little bit sorry I didn't. I rushed into the surgery rather than looking into it further.
Thank you for sharing your vulnerability with us, David. I empathize as well with you. The promise of the presentation today, though, is that you can prepare your knee to recover a lot quicker. Now, what did you find most interesting, or what was your main takeaway from the presentation today, David? You may be on mute, big fella.
I think the main thing was that there was a vast amount of information that no one else has relayed to me. No other medical professional has relayed to me. And I think now I don't know whether they don't have the knowledge that you have, or it's not done. But yeah, I was staggered that I've had this knee for 4 years. I could have been doing something about it 4 years ago.
Absolutely. Not to dive too deep into your own personal situation, David, I can speak to my experience as a practitioner, as a physiotherapist, and just speaking generally, some patients that I've helped manage have come across information, and they decided to delay a procedure to trial a period of time of specific strengthening work and managing the other factors that I touched on in this program. And in this case, these clients I'm thinking off the top of my head, they did very well. And in the presentation, I talked about delaying surgery. So you get more health from the knee, you reduce your pain, your symptoms, you improve your function. And it may be an inevitability because you've enjoyed a long, great life, you've put a lot through the body. So I'm sure there's going to be some degeneration, but there's two ways I think about this. Number one, you're preparing your body for surgery in the near term or the long term. And number two, you're actually reducing the chance of needing the surgery potentially. So those were the ways that I framed up this specific scenario that you're facing. Ultimately, it's your decision. And I think if you have an earnest conversation with your treating specialist, then just come from a place of honesty and just say, look, I'm not sure this is a big life decision. Is there an option available to me where I can postpone for, say, 12 weeks? And if you're in good enough nick if you're functional enough to trial a 6 to 12-week program of conservative management, as the science suggests and this program suggests, this is potentially a way forward for you and your knee, David. So don't feel like you need to make a decision right now. Absolutely review this recording back, have a discussion with your professionals, have a chat to people close to you that you love and trust, and then make the best decision with the best information you have at hand. So hopefully that helps.
Yeah, thank you. I waited 4 years actually on a waiting list to get this knee. Struggled with it for 4 years. So yeah, and now it's coming up next week or week after. So I might just do that. See if I can postpone it.
Again, this is something that you should think about. And given that you may be on a waiting list for a long period of time, but make sure you get great information and great advice. Thank you, David. All right. The next question I have via chat is from Andrea. Thank you for that. Her question is, I understand that GLAD is specific to hip and knee. Does the theory apply to shoulder and widespread arthritis? I've tried exercise and yoga and Pilates, which causes inflammation. Am I missing the guidance to build strength to a point where I can go to the gym without fear of worsening the joint pain? Okay. Wow, that's a meaty question. In short, yes. Now, the thing here is it's specific strengthening work, education, and potentially weight loss, which is a bit different for the shoulder because it's a non-weight bearing joint. Now, in the shoulder, for women, it's the hands and the knees that knock the ladies over in terms of osteoarthritis. But if it's presenting in the shoulder, there's other factors to consider, because in the GLAD program, you can see we're also touching on non-physical factors. Your general well-being. Are there other chronic inflammatory conditions that you're managing? So say if you're a type 2 diabetic, the blood isn't so flash. So your wound healing is going to take longer and you're more susceptible to inflammation. So the way I think about this is, if you have a little Bunsen burner in the shoulder, okay, that's the shoulder injury you have, and then there's something that causes chronic or systemic inflammation, then all the different Bunsen burners in the body, they get angrier. So this little shoulder inflammatory pain that you have, if there's another inflammatory insult, then everything gets quite angry. Does that make sense? So I would say for your specific issue there, Andrea, it would be specific shoulder strengthening work, slowly increasing the load over time, and being kind to yourself, because the body is magic. It adapts really well, but sometimes we can be a bit overzealous and throw too much at it, and it's just not strong enough or not ready. So I would say, yes, there's definitely an opportunity for specific strengthening in your shoulder. No problems. Thanks, Andrea. Guys, we've got about 5 minutes left, so feel free to throw some curveballs. I've had some great ones here. If you have any questions pertaining to your, maybe there's myths, if there's a myth buster that you wanted me to break, but I think there's a lot of information that you've all absorbed today. So Karina's here with us from Westgate Health, and she'll figure out a way to send the recording to you via email. I really appreciate your time and attention, and I look forward to part 2. This is part 1 of a 4-part series, so I hope to see you guys again soon. If you haven't had your lunch already, get something to eat, and I'll see you next time. Thanks, guys. Bye.